morning.
Good morning, Dr. Curry.
Good morning.
Can you remind the jury who you are and what you do?
Sure. I'm Dr. Shannon Curry. I'm a clinical and forensic psychologist, and I'm here today to rebut the testimony that was provided by Dr. Hughes.
And could you please just remind the jury who you are again?
Sure, I'm a clinical and forensic psychologist. I am board certified in forensic psychology.
2 hours later.
To offer a rebuttal testimony to Shannon Curry's testimony of yesterday.
Now, Dr. Curry said you used improper methods. Would you agree with that?
No, I would not.
Why? Please explain.
As I testified to you all several weeks ago, I used a standard forensic procedure that is well established in our field. It is a multi-method, multi-hypothesis-driven procedure where you're looking at a variety of different details and tests and external data to arrive at an opinion, and you're looking at the consistency across that data.
I conducted a very methodical analysis of the scores. I do this for every test, and I also did it when I was reviewing Dr. Hughes's scores. So what you haven't seen that's in Discovery is that I created a 25-page outline just of her scores.
There are three sort of sets of tests that we use as forensic psychologists, and I think that's where it seems that Dr. Curry seems confused.
So Dr. Hughes she stated that she administered 12 tests. In actuality, she used 8 checklists. About half of those were symptom checklists. The other half were checklists about experiences that people can have with domestic violence, and those are not appropriate for forensic settings. They are easily exploited.
What we also do is use a very different types of tests within that category. We use some checklists, some face valid checklists. We use some tests that are those broadband personality inventories. We use structured clinical interviews, and then we look for the consistency across those data points. And when we use different types of tests, it gives us information about the individual, how they go about these tests in these different modalities.
Of the various tests that she administered, how many were these checklists?
8 of them.
All right, and what are you talking about specifically?
Okay. So I had mentioned that there were 2 main categories of checklists she used. The first is the symptom checklists. Those included the Beck Depression Inventory. It's a brief inventory of items that essentially show all of the symptoms of depression that a person might have, and you rate which level of severity you have for each question. She also gave the Beck Anxiety Inventory, very similar, but just with questions about anxiety. She gave the Mood Disorder Questionnaire, which is a very brief, again, checklist. It shows symptoms of bipolar disorder. Bipolar disorder is a mood disorder where you might have an extended manic episode and then a very extended depressive episode. And then she gave the post-traumatic stress disorder checklist, and that is a screening instrument only. It contains every single symptom of PTSD. So there's a secondary danger here too. When you think about it, given that PTSD is the most frequently feigned and claimed diagnosis in civil courts, if you're handing somebody a checklist that lists every single symptom of PTSD, you're essentially teaching them all the little nuances that we're looking for to give that diagnosis. So she gave that to Ms. Hurd. Ms. Hurd endorsed most of the items, and Dr. Hughes diagnosed her with PTSD and substantiated that opinion by Ms. Hurd's checking those items on the PCL-5.
We have forensic assessment instruments. Those are instruments that are very neatly tied to a legal criteria. Those are most notably done in a criminal court for competency. If someone has competency to stand trial, we have very clear measures that can track that legal criteria. The next level are forensically relevant instruments. And those instruments are not linked to a specific legal criteria, but they do have information that's germane to that finding.
So of the tests that Dr. Hughes administered, 2 would be considered. Of those 12, 2 would be considered what we call forensically relevant instruments, meaning that they're objective enough and they provide us with some information about how the examinee approached the test, that it would be appropriate for this setting where the examinee is going to have a natural incentive to present themselves in a way that benefits the outcome of their case.
So the malingering measure that I utilized was the MFAST, and that was the only malingering measure in this case.
She also administered a malingering screen that can be very, very useful, but not in this context. So it's called the Miller Forensic Assessment Symptom Test. It's a brief set of questions that you ask the examinee, and it's been shown by research to be extremely effective at identifying an examinee's attempts to fake a severe mental illness or psychosis. And psychosis is when somebody loses complete connection with reality. It's excellent for that purpose.
It's the only measure of malingering that was done in this case. Dr. Curry did not independently measure malingering, and there are other ones that she could have done to augment her evaluation. And she kept saying something that MFAST is not for malingered PTSD. That's wrong on a couple levels. People who are going to malinger and feign don't only feign one diagnosis. They sometimes talk about all different symptoms that they have, and they exaggerate and they make themselves seem much worse than they are. So when you're doing an evaluation, you're giving a malingering measure to get a sense of how this person is responding to this evaluation.
It's actually been shown in the research to not be effective at all for identifying a respondent's attempts to fake PTSD, anxiety, or mood disorders. The questions are just too odd for somebody who has the wherewithal to be trying to have PTSD to endorse. They see through it.
Now, Dr. Curry seemed to suggest that Amber Heard tested the most extreme category in all of these different tests. Is that accurate?
That is not accurate. They were not on the checklist. I mean, people sometimes do. They go, all the time, this happens to me all the time, frequently. And that is not how she endorsed these tests. She endorsed them in a very moderate way, in a very nuanced way, describing her symptoms that I determined was accurate and reliable.
Let's look back at some of those domestic violence checklists that you were talking about.
Okay.
And did you see any problem with the use of those?
Yes.
What problems did you see?
Well, Doctor, first of all, they shouldn't be used. So we do have professional standards that require that we utilize instruments that are relevant and appropriate for the particular setting, and that we substantiate our opinions based on data that is reliable from tested, accurate, reliable tests for the purpose. So there's that. It's inconsistent with the ethics. And essentially, they just shouldn't be used. They don't provide us with the robust information that it would be expected in such a high-stakes setting.
Now, Dr. Curry also suggested that Amber Heard was tested very, very high, 98 percentile, I think, on malingering and feigning. Could you speak to that, please?
Sure. So, I mean, she said a lot of things, so let's go through those tests. The first was the PAI, and that's that other broadband psychological
Objection,
measure.
non-responsive?
I think it's very responsive.
It's sustained.
Okay. Could you tell the jury about the PAI test that Dr. Curry addressed?
Yes, thank you. So that's the broadband measure that has validity scales built into it that gives us indications about how the individual goes about the test. 98th percentile, which I told you in the manual, all you have to do is read the manual. It says specifically that we do not use the percentile ranks for this test. That indicates to me that, Dr. Curry does not know the psychometric properties of this test, and then she then is therefore not qualified to interpret it.
Yes, on that atypical response scale.
And what does that 98th percentile score represent?
So that 98th percentile score just represents that among 98% of people who take that test would not have endorsed. She scored more of those unusual items that are not consistent with PTSD than 98% of people who have ever taken that test.
Does that relate to this concept you talked about before called feigning?
Yes.
What is feigning again?
Well, feigning is essentially exaggerating symptoms of a disorder.
I told you last time that there was no evidence of malingering or exaggeration or feigning on that test. What Dr. Curry was talking about was this tendency to put your best foot forward to minimize faults on this PAI. That scale was right at the cusp.
Yes. So what's interesting about Ms. Hurd's approach to different tests is that it seems to be influenced by what we call the face validity of questions on the test. So if a test looks like it's measuring PTSD, you see exaggeration on her validity scales. If the test has less face valid questions, for instance, the personality assessment, which Dr. Hughes administered, the MMPI-2, which I administered, where she can't quite figure out what the questions are asking, they seem really banal in general. On those, you see extreme defensiveness, minimization of any potential pathology, essentially presenting herself as perfect and free of any mental illness or personality disorder. But on the trauma symptom inventory, which Dr. Hughes administered, that was the one that I previously indicated for ease of explanation. When the test results come out for how the person approaches the test, that test itself prints it as a percentage. And there's a really excellent scale for finding out if a person is exaggerating their symptoms of PTSD. It's called the atypical response scale. And the TSI-2 is the revised version of this test, and that scale was improved this time around to really try to be a clean indication of, is this person exaggerating? And it puts quite high questions in the test that are so unusual. They might sound like PTSD, but even the most severe cases of PTSD don't have these symptoms. And so somebody who's intentionally trying to exaggerate PTSD, or possibly unintentionally, but nonetheless, who's exaggerating it, is likely to endorse these items, even though they're not real PTSD symptoms. Ms. Hurd scored so highly on this that even if there is, although Dr. Hughes correctly said there tends to be a negative skew when people have the high levels of distress that's associated with PTSD, so sometimes people score higher on this even when they do have PTSD, she scored so high that that is effectively ruled out as a possibility.
And then there are two other measures that we look at that to say, is this enough for an elevation for me to consider that as a serious response distortion, of which Dr. Curry was saying, and it was not.
What test do you believe that Dr. Hughes failed to acknowledge response distortion on?
So she administered the personality assessment inventory, which is similar to the test I gave, the MMPI-2. It's that general broadband measure of psychopathology symptoms and personality traits. It includes several scales that are very good at detecting either exaggeration, minimization, or even trying to claim that you have unusually good qualities. On that test, there were clear indicators that Ms. Hurd, very similar to the way she approached my MMPI, engaged in defensiveness.
Relevant on this test was there were elevations on anxiety, on affective anxiety, meaning anxiety, tension, worry, on traumatic stress, on hyperactivity, and on affective instability. Those were the four scales that were elevated on this test. The borderline scale was not elevated on this test. Secondly, there are 3 scales out of about, maybe there's about 20, a little more on the TSI that were elevated. Intrusive experiences, that's when thoughts and memories of the trauma come into your mind when you don't want them. Defensive avoidance, sort of behavioral ways that we try to push out those memories and not think about them. And then relational avoidance, a way of having difficulty in interpersonal relationships. Those are all trauma-based symptoms.
On the PAI, there were clear indications that Ms. Heard was responding and obtained scores in a manner that's consistent with individuals who have a personality disorder. And there was also an indication that several scales, we call this a configuration. So you might have one main scale that you notice is elevated, then you look for additional subscale information to get additional information on what could be elevating that scale. And there was a configuration that showed that even though Ms. Heard had moderately elevated one of the scales that can be associated with trauma, that elevation is better explained by childhood or distant traumatic experiences like the complex trauma Ms. Heard reported experiencing growing up.
Thank you. Now, Dr. Curry also talked about the danger assessment scale and suggested that you had inappropriately interpreted that. Do you agree?
That's also incorrect.
Please describe for the jury.
Which I told you last time, the danger assessment scale has statistically validated risk factors for serious or lethal domestic violence. Those risk factors exist whether we go forward, we're sitting with someone in an acute setting and assessing them right now, or if we look backward and we look retrospectively about what factors may have been present in a case that indicated severity. That instrument is used in what we call, there's called domestic fatality review boards. Those are boards after somebody has been killed, a homicide has occurred in a domestic situation. They look at these risk factors to see what was there and what could be done.
Dr. Hughes, this is a blank form, but this is the danger assessment test that you also gave to Ms. Heard, correct?
I didn't give it to her. I filled it out based on the data that was provided to me.
Oh, so you asked her the questions and then you filled it in.
It was somewhat collaborative.
First of all, Dr. Hughes provided opinions based on these checklists. So she referenced especially the danger assessment scale several times throughout her testimony, stating that Ms. Heard was in a very dangerous situation. We also have an ethical guideline and a professional standard as well that indicate that whenever there is question about the reliability and the validity, and in psychology we use the term validity to talk about accuracy, of any of the methods that we're using to collect data, we clearly communicate not only that there are limitations to our opinions, but we also need to provide the fact finder with information about what the potential implications or impact could actually.
Will you please explain to the jury?
So the CAPS-5, as you all have heard multiple times, is a structured clinical interview in determining PTSD according to DSM-5 criteria. On this measure, Amber Heard scored in a moderate range. She did not over-exaggerate on this test. She could have said no, mild, moderate, severe, and extreme. All of hers were either 2s or 1s or 0s. None above that. So she's scoring in the moderate range, which still has functional impairments. I mean, we don't want someone to be having moderate PTSD, but that's not an exaggerated profile or exaggerated response style of someone who's answering an instrument.
Okay, yes. So Dr. Hughes had diagnosed Ms. Heard with PTSD back in 2019 when she began testing her. It wasn't till 2 years later, more than 2 years later, 10 days after I administered the CAPS-5 with Ms. Hurd, that Dr. Hughes held an impromptu evaluation session remotely with Ms. Hurd and administered the CAPS-5. She had previously diagnosed PTSD without using what we consider to be the gold standard PTSD diagnostic interview. And again, when we're doing a forensic evaluation, it is an important responsibility, and part of our ethics and professional standards are that we document everything to allow for transparency and full judicial scrutiny. And Dr. Hughes administered incorrectly. She left huge sections, very relevant sections, blank. There's no way to understand why she scored it as high as she did based on the information that's provided. You're essentially supposed to notate the examinee's responses as verbatim as possible to explain your reasoning and implying their scoring procedure. It's a standardized test, and if you don't follow those standard procedures, it's completely invalid. Not only that, but it looks as though Dr. Hughes further invalidated it by trying to show that she had assessed for the childhood trauma impact, and she had said that she went back and asked the childhood question, but you can't do that. If you're assessing for two separate periods of one's life to find out their relatedness to PTSD, you do two separate CAPS interviews, period. You don't create your own question system. That is non-standard administration of the test, and it invalidates it.
Dr. Hughes, Dr. Curry also testified that a victim of PTSD has to effectively be prone and unable to function at all. Would you agree with that?
Objection misstates the evidence.
She said they couldn't hike, they couldn't move, they couldn't function in any shape, way, shape, or
Overruled
form.
objection.
Thank you.
No, that is not correct. That is often actually a myth and misconception about individuals who are struggling with PTSD or trauma-based disorders, and I'm often called to answer that and speak to that. People who are struggling with trauma and PTSD are very strong, courageous, resilient people, even though that they're struggling. They get up, they have to go to work and drop their kid off at school and go to the market, even though they're struggling with these symptoms.
So really, the bottom line in a forensic psychological evaluation is a change in functioning. That's what we're looking for. Again, I said we don't have a crystal ball. We're not wizards. We can't get into somebody's head. What we're looking for were their identifiable changes in the way the person engaged in their world. Were they able to keep a job? PTSD is an extremely disabling diagnosis. When a person has true PTSD, it is difficult for them to work. You'll see unemployment, job loss. It causes extreme levels of distress and impairment. There's divorce, there's isolation and estrangement from children, from family members, extreme alcohol abuse, often a string of sudden DUIs when the person never had any before. They become homebound, they can't go to the store. They're certainly not going to events. They're not having success in their film career, usually. They're not exercising every day, pursuing their hobbies, being avid readers, obtaining level 3 sommelier training, having dinner parties with friends, speaking to public groups. Those are just indications of very high functioning. And when you're looking for a decrease in functioning over time, that is inconsistent with that decrease.
Now, Dr. Curry also said that it is not within the scope of a psychologist to evaluate domestic violence. Do you agree with that?
Of course, I don't agree with that. This is what I do for a living, day in, day out, for 25 years. We are specifically trained to understand the profound impact that trauma has on people's lives. That's what we do in the trauma division of the American Psychological Association. We disseminate that knowledge. And domestic violence is one of those profound traumas. Domestic violence is part of state licensing boards, that you can't get licensed in some states unless you take training on domestic violence. You can't renew your license unless you get training on domestic violence. So people who have, specialized training in this area, it is, beholden upon them to accurately assess for intimate partner violence and sexual violence. And it's more important to assess for this sort of scientific understanding of what domestic violence is. So you have to assess for the physical violence, the psychological violence, the surveillance, the economic, the emotional abuse, and the sexual violence. That is not gratuitous.
When did Dr. Hughes do this most?
She did this most when describing instances of alleged IPV. And there's also an issue there because one of our ethics also discusses the importance of relevance and withholding, essentially constraining our testimony to the data and not including private information, personal information that unnecessarily compromises the dignity of any of the litigants. She provided a lot of what was Ms. Heard's report to her, the allegations of abuse, when describing Mr. Depp, who she had not examined, when describing Mr. Depp's behavior, his motivations. I believe she used the word obsessive jealousy quite a few times, talked about Ms. Heard being in a highly dangerous situation. These are simply things that we cannot detect based on testing and a psychological evaluation. We have to evaluate the person, we have to get consent, and we can only describe an individual, not whether or not IPV has occurred. And we certainly shouldn't go into explicit details about sexual encounters or other things that are highly prejudicial, shocking, and hard to forget.
And then I made my conclusions based on my clinical education, knowledge, and training to come up with a professional expert opinion.
Then I go down to essentially, we call these the first factors. So their overall sense of well-being and how well they cope. On this, actually, Ms. Heard's, she endorsed scores or endorsed items that were the opposite of PTSD. So really saying that she feels free of distress and that she views herself very well. So then I go down to control, self-control, loss of control, coping abilities, and I put in the scores that are associated with that in the research and the test development.
2 hours later.
I looked at the scores that are typical of women with IPV. Hers were not consistent at all with those. I looked at the scores that were consistent with people who are frequently in litigation. Hers actually were very highly correlated with those. That tends to be also consistent with a 3-6 code type, and the reason for that is believed to be that they tend to perceive themselves often as victims who need to avenge wrongs.
Crushing Defeat Media.